Shall we move on to Dr. Praveen?
Yes.
Hi, Praveen. Good afternoon. Great to see
How are
you.
you? Now, so we have patients who have aortic and mitral prosthetic valves done earlier, and then when these valves start failing, generally they are above the age of 65 years. They are high risk for repeat surgeries, and of course one starts looking for options. And earlier we didn't have many options. Now we have options both for the mitral and aortic position. Now for the mitral position, the only option is Sapien 3. And of course, there is an Indian valve which we have, which is the My valve, which is also an option. But definitely Sapien 3 is US FDA approved for mitral valve and valve procedures. So today, I am going to discuss with you about these two possibilities of mitral valve and valve and aortic valve and valve. So, this with this background, you can see that the risk of doing a repeat surgery is high compared to first time surgery. And as you go on to the third time and the fourth time, the risk goes higher and higher. So what are the options? So here you look at the number of surgeries which are being done, because number of patients who are needing a second valve or a third valve is also going up very high, both in mitral and aortic positions. So we need to have option, and this is the one of the comparisons where you can see that if you do a redo aortic valve surgery compared to a valve and valve with the Sapien 3 valve, here you see the difference in terms of all-cause mortality, in terms of disabling strokes, in terms of atrial, all these issues are very well taken care of if one does a transcatheter valve and valve in these patients. And also over a period of time, it's not that it will only be there for a little while. It is consistent. The results are quite predictable, and you can see at 3 years follow-up, the quality of life, the functional class, everything remains quite consistent if you use valve in valve procedures. And the device success, the all-cause mortality, the risk of stroke at 30 days, all has been found to be very, very positive in terms of using a valve in valve procedure. So this is you started from native valve, but now we are today talking about aortic valve in valve and mitral valve in valve procedures. So this is how we have to start identifying these valves, and so many models are available. And now so these are the pictures which are now available on an app which is developed by Dr. Bapat. And here he has given all the photos, the radiological pictures, so you can identify these valves radiologically also. Which one is this? And also one has to look at the records. One can do a CT scan, all those things to identify which is the type of valve, whether it is a stented valve, stentless valve, what you will see on the fluoroscopic image, all that can be known. However, when we have these patients who have valve issues where the valve is degenerating, it can lead to two things. One, it could be a mitral stenosis or aortic stenosis, or it could be a regurgitation at either of these valves. So how does it happen? It happens because of degeneration, but we have to be careful. Because sometimes when these patients come with the increasing gradients across the valves, it could be thrombosis also. So one has to consider this in early valve issues. And many a times we have seen that if you put these tissue valves also, and has been shown in some CT studies also by so many now big trials showing that valves do thrombose, even the tissue valves. And then in these patients, giving them on antithrombotic, putting them on antithrombotic regimen might also reduce the gradient sometimes. So one has to try that. And second is, in those patients, especially who come with regurgitation, infective endocarditis possibility also must be ruled out. So these are the two, kind of tips which I wanted to share. And then, which kind of valve we can use. So for mitral valve, only the balloon expandable valve is recommended. You cannot use a self-expanding valve. However, for the aortic valve and valve, you can use either types, either a balloon expandable or a self-expanding valve. Now, many times the annulus is small. So what do we do in these patients? You can either choose a self-expanding valve, or if it is too small, we still want to break it, then we have to break it using Atlas Gold balloons or stiff balloons, non-compliant balloons, and we can increase the size of the valve frame. However, only valve where we cannot do this is the trifecta valve or maybe the mitral flow valve. So I'm just quickly moving to one of the cases, and there is where a valve was implanted in a severe degeneration. Patient was with severe acute aortic regurgitation happened because he was degenerating, and suddenly one of the leaflets just went off, and the patient went into severe, heart failure, and then the patient had to be kind of treated very rapidly. So this is the sizing remains the same, and here you can see that there are two apps, the valve and valve aortic app and the valve and valve mitral app, which you can download on your phone, and through this we can find out what is the ID of this particular valve which is to be done, which is there already, and then based on that we use select the valve, and this is the picture is also available where you can see how to position these valves in these valve and valve treatments. So in this patient, you can see that this is a stented valve, and this was a small valve though, but it has worked for about 10 years or more, and then now it is degenerated. So we then decided that he has to be treated quickly, and this was very bad corona times. So the patient couldn't be moved anywhere. He was admitted in ICU. So we immediately did all the CT and did the sizing and the which access we have to take. There were some tortuosities in the iliacs, but certainly the other accesses were equally bad. So we went from the iliac artery, and as you can see, the size was okay. So we moved, and here is the picture. I just wanted to share with you that this was a very bad situation of COVID at that time. So we moved there, and then we did an angiogram, which was okay. And at the same time, and soon after that, the valve was crossed the same way as we crossed the native valve. The cross is in the same way, and then followed by this now the wire, which is a safari wire, and then now once the wire was in position, no pre-dilatation is done. Typically, this is one of the things which I wanted to share, that there is no need to do, there should not be done actually pre-dilatation, and then the valve was positioned across this, as you can see here, and then the patient was paced at high rates, and this is the implantation which is happening at the aortic valve. So this is how it looks after the implantation, and soon after that we checked the gradients, everything is okay, and the patient did very well after that. So that is a typical set of steps which we do in aortic valve and valve procedures. And the Sapien 3 valve is a very predictable deployment in these bioprostheses, and a short frame actually is beneficial for future coronary access. So why I'm emphasizing this, because this is a young patient, and in this patient he might require a third valve also at some point in time. So in this kind of cases, using a balloon expandable has this kind of advantage over here. However, self-expanding, one can access coronaries, but it becomes a little difficult and tricky at times. Now, just quickly about the mitral valve, we have now many patients where we have to do mitral valve and valve procedures, and the only valve you can use is a balloon expandable valve. Again, you have to identify the valve and then see that what is the true ID, and based on that we decide which size of valve we use. So in this patient we decided to use a 26, and the second thing which we have to look at is the aortomitral angle. And here in most of the Indian patients, this is not a big issue, because most of these patients actually have removed the mitral valve apparatus. So in this, generally there is not a problem. But in those patients where after surgery or during surgery the mitral valve apparatus has been spared, then it becomes a problem. So the typical setting is general anesthesia, TE guidance always, and then we use this valve through a right femoral venous access, and the septal puncture is done through a T-guided approach. And this is sometimes, if the patient is too sick, we can have some support, etc. But nowadays we don't need any support. No, dye is used in this procedure, and we do a septal dilatation first with a 12 millimeter balloon, and then once the dilatation is done, we quickly take the valve inside and go ahead with the rapid pacing. And then it's not 100% required to do rapid pacing, but certainly I do it always. And you can see that once the procedure is done, the valve is in position. Since this patient had RV dysfunction also, so we close the atrial septum through a device. So while coming back, but 50-60% times, 70% times, we don't even close it, because if the RV function is good, they tolerate it well, and over a period of time, it closes off. And these are typical echoes. We can see no PVL, and the patients start improving immediately. So this is how things are. So to conclude, I think Sapien 3 valve is a good option for failed bioprosthetic valves in both aortic and mitral position, with both stenotic and regurgitant lesions, with a high degree of safety and efficacy. So we have done now a reasonable number of these valve and valve procedures. More are with mitral and many aortic valves also. So we are quite happy, and the patients are really doing well with these valve and valve procedures. Thank you very much.